Hi, everyone. It's such a pleasure to get to talk to you today about deprescribing medications. And who better to do it than a pharmacist? When I first went to pharmacy school, I thought I was going to learn about how to promote drugs, because that's what a lot of people say, oh, you're a professional drug dealer. And after I graduated, 7 years later, I realized I'm more of an advocate of deprescribing than prescribing, but prescribing has its benefits too. So here I am talking to you about deprescribing. Just to frame our mindsets around what we're going to be talking about for this next hour, I'm going to read to you these goals and learning objectives. The goals is to integrate high-level interpersonal communication and negotiation skills into clinical practice when deprescribing benzos and opioids. Deprescribing pharmacotherapies to avoid and those that are potentially inappropriate in older adults. And learning objectives are two: to identify common pharmacotherapies to avoid, monitoring parameters, safety guidelines, and lifestyle modifications in patients across a lifespan, and then to discuss healthcare provider patient cases reflective of living well and deprescribing across the lifespan. And so what I will be talking to you about is building relationships with patients across the lifespan, specifically with pharmacotherapy recommendations, focusing on prescribing cascades, medication misuse and overuse, and co-prescribing medications. And then emphasizing resources that are available through therapeutic communication, the power of team, and prescription monitoring program. So this prescribing cascade, when I created this pictorial here, it was almost like, what came first, the chicken or the egg? Well, we definitely know what comes first in prescribing cascades, and it's that initial drug therapy. And so what I began to think about as I was looking at this picture is a slinky. Patients' lives are more complex than just one flat, we're going to prescribe, and then we see an adverse drug event, and then we prescribe something else to cover that adverse drug event, and then the increased adverse drug events increase, right? Well, we know that we're not the only ones that suggest patients take medications. We have the World Wide Web, which puts a lot of information at patients' fingertips. And they either look up medications that they need to take over the counter, or they find out that a friend has been prescribed this medication and then find out what that medication is for, and they take the medication. And so these prescribing cascades are more complex than what we as prescribers can create, but that can be a possibility as well. So it's important to keep in mind that people of all ages can be affected. Here's some examples of some prescribing cascades for those of you who have access to UpToDate. This is a great place to start, just to begin to refresh your mind of what can be happening when patients begin to take particular medications. In the first column, you see the initial drug therapy. Then in the second, you see the adverse drug event. And then in the last column is what we prescribers will typically prescribe to cover that adverse event, seeing it as something that maybe is a new disease state for the patient. It can actually be a problem of a medication. So antipsychotics, those are really well known for extrapyramidal side effects and symptoms that patients may have, and can lead us to treating a patient with an anti-Parkinson's disease. Or cholinesterase inhibitors. So we're giving a patient a medication to help treat, what is a cholinesterase inhibitor for? That's so weird. I just looked at your faces and forgot. Okay, yeah, that could be it. That could be the case. Typical ones that come to my mind are Alzheimer's disease. And what can happen is acetylcholinesterase actually increases, and so muscle tone begins to change, and urinary incontinence can occur. And so lo and behold, a lot of times women will complain of this who are on cholinesterase inhibitors, and we prescribe them something to help with incontinence. Thiazide diuretics, those will tend to help the body to reabsorb uric acid, and so we will see increase in gout treatment as a result, instead of just changing to a different antihypertensive medication that may be more effective for the patient. And then NSAIDs can increase blood pressure at the level of the of the renal function and increasing those antihypertensives for patients. So a lot of times we think, well, maybe more information will get me better results for my patients if I know what to not prescribe as a result of an adverse drug event. And that can certainly be the case. And so here's some other additional examples that I can give you here. One that tends to be the biggest problem is non-steroidal anti-inflammatories, typically ibuprofen, because it's available to patients readily. And patients will even begin to take ibuprofen PM, right? That's another problem that we'll talk later on. And so dizziness can occur. There are lots of case studies to support neurologic sequelae as a result of taking ibuprofen. So this is something to look close to with patients as well. So the risk of prescribing cascade, nobody is immune to this problem. I found an interesting article in the New York Times that was published in JAMA by a pharmacist. And this pharmacist's mom was experiencing prescribing cascades twice. And so she first just deprescribed one medication, and then it happened to her mom again, was sent to the hospital. They recognized that it was a result of prescribing cascade. So typically 30%, we see 30% of hospitalizations are a result of adverse drug events. And so we can help to reduce hospitalizations considering thoughts of deprescribing medication. And so anytime we think of prescribing medication, think of also deprescribing. What else is that patient on that they may be taking that maybe we don't need to directly treat, but if we remove the drug, maybe the side effect can begin to ameliorate. So not everything is a new problem. Consider side effects of medications. Consider deprescribing just as much as prescribing. Sometimes deprescribing will require titration. Sometimes it will not. And so depending on what that medication is. Every time a new medication is prescribed, though, consider that possibility. Is my patient experiencing a symptom that could be the side effect of a current medication that they're taking? Not only the prescription medications that they're taking, but also the over-the-counter medications that they're taking, or maybe a medication that they got from a friend who was trying to be helpful. Or herbal products. Herbal products can take the place not only of tablets and liquids, but also teas, things like that, thinking about what the patient is putting into their body. Any sort of exogenous product that can cause a side effect. So I'm going to step into the space of medication misuse for just a bit, and something that we're seeing in our society, and we've been seeing this rise over the last 30 years. And we've seen it become a problem. Anytime patients need sleep, they're desperate. They want to be able to sleep. They want to be able to have a good night's sleep. And we know that benzodiazepines and the Z drugs that I have listed here, those can help promote sleep. But it's only a temporary fix. It's only something that can help a patient with a limited time. And it's not just because maybe we won't give them refills, but even if a patient does get access to refills, we see that utility of these medications are quickly lost over time. And the problem with these medications, once we begin to try to taper the medication off, taper the patient off of the medication, they start to exhibit worse symptoms. And so they think that we're doing something that is not useful for them. And so consider this when prescribing either benzos or Z drugs, is that that education about acute use, or that education that eventually, even if you do happen to get access to it long-term, it's eventually going to stop working and you're just going to need more and more and more. These types of things require relationship with patients, because a lot of times patients, especially when you're sleepy, you're not thinking clearly, right? So think of a patient in that mindset. And sometimes we turn childlike when we're not thinking clearly. But when we have a good relationship with our provider, that can actually make a huge impact. And so, so I think just emphasizing that relationship with our providers is so important. And this stopped working here. All right. So deprescribing medications, getting a buy-in beforehand. So dropping that in their mindset ahead of time. This is not something that is a long-term fix. For patients who have been taking these for long-term, because I will have patients that will come across my way who have been taking benzodiazepines. I get that buy-in that they're ready to taper off. A slow taper is important. Typically about 25% every 2 weeks would be useful. If a lesser reduction is necessary to help patients not have that withdrawal syndrome, that can sometimes help. But you can go anywhere from 12.5% reduction to 50% reduction, and let the patient be your guide. If you want some access to really great education materials, these two trials, Empower and Deprescribe, would be great ones to look for to provide good education materials for patients ahead of time. Diphenhydramine. This medication seems like it's in everything. It makes me think of my big fat Greek wedding when they used Windex to treat everything. Well, sometimes patients, it seems like they go to diphenhydramine to treat everything. And it really gives some pretty nasty side effects, dries people out, and it can even lessen their ability to make sense of things if taken at really high doses. If the words that you have to share with your patient about titrating them off of the medication doesn't make an impact, maybe what could make an impact is a day to remember. We actually have a national day now, August 31st, which is an International Overdose Awareness Day. And sharing facts with patients can sometimes be helpful depending on the bent that patients have. So if you're looking for facts, CDC has a great place about a day to remember in our International Overdose Awareness Day. Naloxone is a medication that is typically prescribed, particularly with opioids. A lot of times patients will take both benzodiazepines and opioids together, but naloxone will still work even though both of those are taken together. It's important to have the naloxone conversation with patients because naloxone has a stigma associated with it. I'm not a drug user. I'm not a drug abuser. But when they get that education from their provider, somebody who they trust and who they know about naloxone, studies have demonstrated that patients are actually more likely to fill the prescription, which can save lives. So co-prescribing with naloxone opioids. I forgot that I put this picture in here as an example. I wasn't anticipating that you would ask me my fun fact. So here we go. So it just popped up in there and I just already showed you the information that was in the prior slide. So this picture here is to remind each of us that our relationships with our patients is equally, if not more, important as a medication. Actually, there are many studies that have shown that relationships with our patients are equally as effective as a medication. We see time and time again studies that have demonstrated improved A1Cs as a result of patient-provider good relationships, improved hypertension. We see something that is so difficult to treat, improved pain in patients who have good relationships with their providers. Studies support that patients are more likely to take the medications that they're prescribed when they do have a good relationship. And so that could be one of the reasons why there's greater efficacy. Think of your team. It's not just about prescribing medications, but it's also who else is on your team to help with pain, for example, or difficulty sleeping. So relaxation methods or tactile strategies, teaching patients about stroke and massage and acupressure, music, art, meditation, finding out what excites patients, what types of things are they interested in, and can they do more of those things? And then using our colleagues in OT and PT. Pain management programs, they can really focus and give that attention to patients who may need more attention as far as pain management is concerned, and then geriatric clinics. And one thing that I don't have on this list here is also including your pharmacist in not only in the outpatient pharmacy, but also in the clinics. Because pharmacists in outpatient pharmacy, because of COVID-19, there's such an inundation in outpatient pharmacy. It's chaotic out there. And so we need more pharmacists in the clinics to be able to do these medication reconciliations with patients. So PMP program is something else to put on your list if you are not familiar with it or not yet using it. It helps us to know when medications have been prescribed to patients last and how to best prescribe medications like benzos and opioids for patients. So that is the end of my presentation. And Melanie, I'm going to call you up. And so this, while she's coming up, I'll share this with you guys. I didn't realize I put my art in here. So here's one of the things that I've painted. This one is on sheet music. And then another one is here, it's a watercolor. Thank you for your attention. Have a good day.
Well, good afternoon, and thank you, Krista, for setting me up so nicely. So we're going to continue on this theme of talking about deprescribing and think about some tools for you to use as you're working with your patients. And I will echo exactly what Dr. Salazar just said, in that having a pharmacist as a part of your team is really essential. As we think about all the things that we've been talking about in this world of where everything is drug-induced until proven otherwise, you need a pharmacist. And making sure that we're incorporating those components into that. But the tool that I want to share with you is I want to talk a little bit about the Beers criteria. And I know it's Friday night, but we're not talking about alcoholic beverages. But we are going to talk about potentially inappropriate medications used in older adults. How many of you are familiar with the Beers criteria? You've at least heard of them, okay? They were originated in 2012 by Dr. Mark Beers and colleagues, and they've been updated several times, with the most recent version being updated in 2019. And as you will see, they are lists of medications or classes to avoid in older adults. And you will see some of the things that were already mentioned prior as we look through these, but I just want to highlight some of the medications that you should be aware of that we definitely see commonly used. First, starting with those medications that are independent of diagnosis. So if a patient is taking that medication, it doesn't matter what other diagnoses they have, they are potentially inappropriate and they may cause side effects. So starting with things like meperidine or Demerol has a very long half-life and a very long metabolite also has a half-life with high CNS side effects. So in general, a medication we're going to avoid. That being said, we may use it in a hospice setting, but not in a general pain clinic in an older adult. Also thinking about those oral non-COX selective NSAIDs, things like indomethacin, ketorolac, avoiding chronic use of all of them unless they also have a gastroprotective agent. So making sure they have an H2 receptor antagonist on board if they're using a chronic NSAID, as we try to avoid the GI bleed risk. And that also goes true for aspirin, higher than 325 milligrams per day. Skeletal muscle relaxants also fall into this category. They have questionable effectiveness and they have very high anticholinergic side effects. So another one of those medications that we think about avoiding. And as we think about these different medications, some of the concepts that we want to think about are what are the changes that are happening from a kinetics perspective, and what are the changes that are happening from a dynamics perspective as we age. We know that as we get older, from a pharmacodynamic perspective, our brain is more sensitive. We have various conditions that may be going on in our cardiovascular system. whether it's coronary artery disease, we have a history of an MI, we have peripheral vascular disease, we have atrial fibrillation. All of those things can contribute, as well as changes that happen in the gastrointestinal as well as the genital urinary system, whether it's talking about changes in terms of having urinary incontinence, or it's talking about urinary retention, or as we just mentioned, thinking about that risk, that increased risk for GI bleeds in our gastrointestinal tract. On the kinetic side, we see changes across absorption, distribution, metabolism, and elimination. Starting with elimination, as we think about the primary source and route of elimination is going to be through the kidneys, and we do see decline in renal function as we age. With regards to metabolism, thinking about our liver and what that means in terms of those metabolic enzymes and the potential not only for drug-drug interactions, but also for potentially seeing extension and duration of those medications as they're not metabolized as quickly. And we also see changes in distribution as well as absorption. And then we come back and we put that into action as we think about some of the other medications that are included in the Beers criteria. We look about the psychiatric and the CNS medications, as we think about some of the antidepressants. The ones that you're seeing there are all medications that are either tricyclic antidepressants or in the case of paroxetine and SSRI, but they all have strong anticholinergic side effects. So these are going to be the ones that we want to think about alternatives. So for example, instead of using paroxetine, let's think about using a different SSRI with less anticholinergic side effects, less risk of orthostatic hypotension. We also see our hypnotics, the anxiolytics, as was mentioned earlier, our benzodiazepines, as well as those non-benzodiazepine Z drugs. And then we also see some antipsychotics in there, the first and second generation antipsychotics that we try to avoid. When we talk about the cardiovascular system, one of the biggest risks that we think about is what is that risk for falls in this older adult that is here in front of me. And whether it's the anticholinergics that we just talked about, like a tricyclic antidepressant, it may also be any number of our antihypertensives. So for example, an alpha blocker like doxazosin, prazosin, terazosin, all of those high risk for orthostatic hypotension. If I have a gentleman with BPH, a much better choice for treatment of his BPH is going to be use of tamsulosin or Flomax that has much less risk of orthostatic hypotension than say doxazosin. And that's a nice easy switch to reduce that risk of falls, reduce that risk of orthostasis. We also see orthostasis with things like clonidine that we like to avoid, methyl-dopa. So thinking about those as we look at patients with heart failure, thinking about avoiding amiodarone as first line in atrial fibrillation if they also have heart failure. Similarly, avoiding digoxin if they have atrial fibrillation or heart failure. So thinking about some of the combinations, some of the disease states that we need to consider. In looking at our endocrine system and our GI, probably, well, I would say of this list, the two most common medications that I see used on a regular basis that likely should be deprescribed. One is the first one on the list, the sulfonylureas, recognizing that older adults are much more sensitive to hypoglycemia. And we want to avoid glyburide, glimepiride, clopropramide. So thinking about discontinuing those sulfonylureas. Also not using sliding scale insulins, again, increasing that risk for hypoglycemia. And then the other one that is on there is the very last one, super common, right? In terms of use of proton pump inhibitors with that increased risk for not only C. difficile infections, but also increasing that risk for osteoporosis, as individuals are not able to absorb as much calcium when you have taken a PPI and you've modified the acidity of the stomach, and that calcium carbonate can't dissolve and be absorbed. So unless they're a high-risk patient, you really want to avoid using them longer than 8 weeks. So if you've got somebody who needs to be on a chronic NSAID, high risk for bleeds, perhaps you're using a PPI. But in general, you want to think about some other alternatives for management of that pain. And then coming back to a few other anticholinergics as well as some anti-infectives. Another one of the most common medications that's on the Beers list that gets used on a regular basis, diphenhydramine, oral diphenhydramine, right? As was indicated earlier, it's in all those PM products, whether it's a Tylenol PM, an ibuprofen PM, a sleep aid, whatever it is, you can find diphenhydramine. Very much has significant risk for all of the anticholinergic side effects, increased sedation, as well as that orthostatic hypotension can occur. But the other antihistamines have equal risk as well, so it's something to think about. And then I'll also point out the nitrofurantoin that's on here. That you want to make sure that you're avoiding using nitrofurantoin for long-term suppression when they have a creatinine clearance less than 30. So being aware of those individuals that have a reduction in their renal function, and they may have been on nitrofurantoin for the last 10 years, but over time, their renal function has declined. So making sure that you're taking that opportunity to discontinue that nitrofurantoin. Moving on to looking at drugs in combination with diseases, you'll see a number here and a couple of repeat performers. But as we look at individuals that have heart failure, avoiding the NSAIDs, avoiding the COX-2 inhibitors as they may make heart failure worse, avoiding medications like verapamil as it relates to reduced ejection fraction. If they already have pre-existing syncope, again, we're avoiding the tricyclic antidepressants and the alpha blockers and the acetylcholinesterase inhibitors as well that we use for dementia. The other piece, and we could spend a whole conversation around, what are all the medications that potentially could cause delirium in an older adult? And I think through a delirium mnemonic, when I think about that, and to include in that are things like electrolytes and low oxygenation and infection, but absolutely medications are a part of that. So when you see somebody, whether it's a new onset delirium or maybe it's a dementia that has gotten worse, think about the fact that they may have a drug-induced delirium on top of their dementia. And thinking about medications like that diphenhydramine or that tricyclic antidepressant, all of those can potentially cause delirium. Benzodiazepines, opiates, those skeletal muscle relaxants, all of the above. And the same is true for dementia as well with some of those medications. The other thing that I think it's an important role for all of us is how do we prevent those falls in our older adults? So thinking about some of the medications that may increase that risk for falls. So we've talked already a lot about that risk for orthostatic hypotension, but what about other medications that may be more sedating or may increase that risk? So you see several listed there. The anticonvulsants, our non-benzohypnotics, our opioids, all of those are ones to think about. And then if we have a patient with Parkinson's disease, we want to avoid medications that are anti-dopaminergic. So that means our first generation antipsychotics, things like haloperidol. It also means antiemetics like metoclopramide or Reglan, prochlorperazine, because all of those are going to make their Parkinson's movement worse because of that antidopaminergic activity. If you need to use an antipsychotic, your better choices are your second generation antipsychotics, like quetiapine or clozapine, but usually quetiapine has the fewer of the side effects of the list. And apparently the quetiapine put us to sleep. Okay. So continuing on and thinking about diagnoses and drugs in combination, certainly if they already have a pre-existing gastric ulcer, we're obviously going to avoid NSAIDs and high-dose aspirin. If they have stage 4 or 5 kidney disease, we're avoiding NSAIDs. In women who have urinary incontinence, thinking about avoiding all types of either oral or transdermal estrogen. They both routes have been shown to make incontinence worse. And then in our men with BPH, avoiding those strong oral anticholinergics as well, because that will make it much more difficult to empty the bladder. And then we also have some medications to be used with caution. So aspirin for primary prevention if you're 70 years of age or older. Thinking about medications that we need to adjust for renal function, like dabigatran if you're over age 75 years of age and you have a creatinine clearance less than 30. And then thinking about things like using trimethoprim sulfamethoxazole or Bactrim, which can increase potassium levels when used in combination with, say, an ACE inhibitor or an angiotensin receptor blocker in a patient who already has CKD. So just being cognizant of some of those potential laboratory components and monitoring that you need to do when using some of those medications. And then if you look in the Beers criteria, you'll also see a big long list of potentially important drug-drug interactions. Some of them are ones that you would likely guess. Using an opioid and a benzodiazepine together increases that risk for overdose. We have lots of warfarin drug interactions, increasing risk for bleeds. Theophylline, ciprofloxacin, increasing risk for theophylline toxicity. So just some select drug interactions to think about, but certainly not an all exhaustive list. My apologies. It does not seem to want to move forward. Okay. And then I've included here a list again of some more of those medications to think about that you may need to adjust based on kidney function. So certainly you see things like enoxaparin and rivaroxaban where dosing needs to be reduced, as well as things like gabapentin, very commonly used, not as an anti-epileptic, but for peripheral neuropathy, where we do need to make renal adjustments because gabapentin is 100% renally eliminated. So if they do have renal impairment, we absolutely need to adjust those doses. So to kind of give you a perspective, you're thinking, yeah, that's interesting, but you know, are patients really using these medications? And the answer is yes. If we look at the literature in terms of what is the prevalence of inappropriate prescribing in different settings, you'll see I've listed several studies here, everything from the Goulding study in ambulatory care visits, where 7.8% of visits had at least one potentially inappropriate medication, all the way through nursing home eligible patients in ambulatory settings, where we're almost up to 40% of visits had at least one potentially inappropriate medication. So if you're working with older adults, you absolutely are going to see these medications, and I hope you take these to heart as you manage your patients to help to optimize and reduce their risk, and think about just as important to deprescribe as it is to prescribe. There are some alternatives that are out there in terms of thinking about safer medications. They started to publish some separate companion pieces to go along with the Beers criteria in 2009, but they have not completed that set. They did publish one that are preferred medications for central nervous system medications in older adults. And they continually are working on new alternatives. We also have the stop and the start criteria. And this was developed out of Europe, out of Ireland. And it looks, instead of not only just stopping medications, but it looks at screening and starting medications. So it has a couple of different approaches to that. So you've got screening tools for older person's prescriptions, which is the stop part. And then we've got the screening tool to alert doctors to the right treatment, which is the start. So that is another tool that can be used as well. But I think, you know, the key really is thinking about prescribing cascades. Think about the fact that side effects that you may be seeing in front of you aren't necessarily a new diagnosis per se, but may actually be an adverse drug event. And thinking about medication misuse and overuse, thinking about how we prescribe, how we deprescribe, the importance of tapering for certain medications, as well as co-prescribing. As an example, if they're on a chronic NSAID, thinking about the GI protection. And thinking about that therapeutic communication, that relationship building, and the power of team and what we can do together. Also thinking about those changes with pharmacokinetics, those changes with pharmacodynamics as we age, and knowing that adverse drug events are common in our older adults. And successful drug therapy means choosing the correct drug, or the correct dose of the correct drug for the condition and that individual patient, and making sure that you've got a monitoring plan in place. And consider prescribing when medications, deprescribing when medications are potentially inappropriate or unnecessary. So let me share with you a case and see what you think. So I have an 81-year-old female, and you see her problem list there before you. She's had multiple strokes. She has osteoarthritis, she has type 2 diabetes, peripheral neuropathy, coronary artery disease, hypertension, hypothyroidism, hypercholesterolemia, osteopenia, urinary incontinence. She's had recurrent pyelonephritis, atrophic vaginitis, and reactive airway disease. Here is her first page of medications. So she's on levothyroxine, lovastatin, clopidogrel. She has sublingual nitroglycerin, furosemide potassium, clonidine, metoprolol, Novolin 7030, the glipizide extended release, She has a conjugated estrogen vaginal cream, gabapentin, amitriptyline, hydrocodone, alendronate, tolterodine, and an albuterol inhaler. Then she also has some docusate, some mineral oil, glycerin suppositories, aspirin, diphenhydramine, calcium, and glucosamine. Here are her vital signs. So she has a blood pressure today of 168/63, with a heart rate of 79, respiratory rate of 24. She complains of pain of 1 out of 10. You see her laboratory values there. Her hemoglobin A1C is 6.8% with a TSH of 5.68, and you see her lipid panel. So, what are your thoughts in terms of how you would want to manage this patient? Great comment. So the first comment was making sure that she's actually taking them, right? And that can be, again, another good reason to do a little bit of deprescribing, to help with adherence and help to find some strategies to be able to help improve their adherence. Yep.
Does she really need to be on Constipation and aspirin? Probably maybe not a good idea. There's a lot of issues on the GABA, the combination of everything is actually. She looks like she really needs someone to do a med rec on her.
I was going to repeat, but go ahead. Thank you.
So I was saying, when we look at her HA1C, it's very low for someone her age. So she definitely should be taken off the glipizide, and maybe a consideration of not using the insulin that she's on. And then also just looking at some of the combination of like the amitriptyline, the gabapentin, and the hydrocodone with a pain level of 1, that seems like maybe that might be overkill and put her at risk for falls. Her levothyroxine needed to go up, just on a side note.
Well, do we need to go up, or is she taking it correctly, right? Back,
Well,
back to
that's
the previous comment.
exactly.
Yeah.
It seems like with patients like this, part of the problem is we're so busy in primary care, and there's so much that it's overwhelming. So actually it's made me think that I need to just have some of my older patients come in and spend an entire visit looking at the medications and just really just focusing on that by itself.
Yeah. Or we saw on the second page, she's on a number of medications for constipation, and you just mentioned the amitriptyline. She's got her hydrocodone. So she's got several medications that are going to increase constipation. You mentioned her A1C is at 6.8. We think, great, she's really well controlled, right? Maybe too controlled.
Right.
And then I start, because remembering that A1C is a 3-month average of your blood sugars all day long, right? So she might have some highs, but she may also be hanging out down here in the 70s at times. So
and having a pharmacist to help us would be great. Unfortunately, that's usually not the case. So we really have to mostly do this ourselves.
Well, I hope that is changing. Other comments? One behind you right there.
So she's on 4 different medications for blood pressure, including the clonidine and metoprolol, which is a terrible combination. And she's not on an ACE inhibitor or an ARB, despite the fact she's got diabetes, and her blood pressure is still poorly controlled. So I think that would be a place to focus on too.
That is a fabulous place to start. And I didn't make this person up. This is how she came to me. So other thoughts? Yeah, I think you hit a lot of the highlights in terms of opportunities for improvement, some opportunities to deprescribe, to keep her safe, keep her vertical and not fall, to optimize her blood pressure medications, for her blood sugars, And certainly to spend some time talking about medication adherence and about appropriate techniques to take medications like the levothyroxine, making sure it's on an empty stomach first thing in the morning, all those good techniques that hopefully our patients know but don't necessarily practice or may not ever know. So I think having that time, at a minimum, especially for complex older adults, at least once a year, if not more often, to sit down and just talk about medications is huge in terms of how do we better improve their care, how do we keep them safe. And I know I'm tooting my own horn, but I can't speak enough to having a pharmacist as a part of your team. One of the nice things about pharmacists here in New Mexico is we do have an advanced practice license referred to as a pharmacist clinician, which allows us prescriptive authority and allows us to do a lot of the chronic disease management to help to offload all of you. And we recently, and we're in the midst of implementing a new bill that's going to allow us to bill and get reimbursed by Medicaid and commercial, which will change the picture too. So we're hoping that we can help to offset this gap and this lack of primary care providers that we have in the state. So I love being able to work side by side with my physicians and nurse practitioners and PAs at our senior health clinic. It just makes for optimal care for these complex 80-plus-year-old individuals. And I hope that we can model clinics like that all over the country to really improve care. So any other comments and I'm happy to take questions as well.
So it looks like we have 5 minutes. So if you have questions, shoot your hands up and I'll run over the mic to you and, oh, right here.
So if we were considering getting them off gabapentin, pregabalin is not on Beer's criteria, right? Would that be
It is.
an okay
Yeah,
transition?
pregabalin would be an okay switch. Or just lowering the dose and the frequency actually of the gabapentin, depending on where their renal function is, would be an okay place to go. Yeah. Why does she take albuterol once a week? That is a great question. Whether, and that would be, again, doing a little bit of a deep dive to figure out why is she choosing to use that albuterol once a week? Is she triggered by certain allergens? Is she using it, related to her cardiac status and it's not really her lungs? I mean, it could be any number of things. But or she's just really well controlled, perhaps, right? And only needs to use it once a week. Other questions, other thoughts?
Rather than Deprescribing because it has less side effects. I mean, the team covered that well.
So the question was related to using Myrbex as an alternative to either the tolterodine or even perhaps oxybutynin for urinary incontinence. And I think it generally does have a better side effect profile. So I think it's a good option, but I think what you alluded to, is it being covered on formularies? And that's the bigger challenge. I think with time, we're going to see that it will be covered. Let's see, I saw another hand over here.
I was just wondering how long
So the question was how long has she been on the vaginal estrogen and why? So she has a history, if we go back a slide, she has atrophic vaginitis. So that was the original indication for the vaginal estrogen. So then the question, was it started at the same time as the Detrol? Hard to say. It could have been. Right, yep. So how much is she using? Is she using a small amount that's appropriate? Or is she using a larger quantity? How is that influencing her urinary incontinence? Those would all be things to think about. Yep. Yeah. This does look like a full-time job. Yep. Yeah, it is. I mean, when I see, this morning when I was in clinic and they were bringing in their bags, and it is a full-time job, especially with some of these medications where you have to take them fairly frequently, or they have to be on an empty stomach, and then we'd like you to check your blood sugars while you're at it too, right? So we add to it.
Supplements as well,
Yeah.
They get sold so many things they don't.
Mhm.
They'll bring in thousands of dollars of supplements.
Yes. They absolutely, and then they've got the extra supplements. And I think that, and you raise a really important point, as we think about taking a medication history, make sure you're not only asking about these prescription medications, you're asking about their topicals, you're asking about the things that they use on their skin, that they use in their nose, that their inhalers, but also the supplements, the vitamins, everything, and ask them to bring it all, and the PRNs, because they get omitted 95% of the time. So make sure you take that time to take a really good comprehensive medication reconciliation when you're working with your patients. Okay, well, I see my time is up. It has been a pleasure to be with you today, and hope you take a few pearls home with you. And remember, everything's drug induced until proven otherwise.
Thank you so much, Melanie. We really appreciate you guys' knowledge because it's vast. So with that, we will turn to a couple more announcements, and I have a great announcement. It looks like we only need one person to donate blood, and we've made 26 pints today. So that'll be great. We are fixing to go on break, about a 30-minute break, and we'll come back at 4 o'clock for peripheral neuropathy. Just a plug for some of our vendors out there. I don't